thanks for all organizers who let me to share my topic here. The topic of my lecture will be on physical therapy for female hypertonic pelvic floor. And actually, I focused on the paradoxical puborectalis syndrome because in the clinical practice, in the clinic of the Faculty of Physical Therapy, South Valley University, I noticed many cases that complain from paradoxical puborectalis syndrome. Yeah. My name is Mohamed Gamal Shehata. I am a lecturer of physical therapy for women health, South Valley University, Egypt. I am an associate alumnus, Harvard Medical School, the USA. I am a licensed physical therapist, New York State, the USA, and I am a former PhD researcher at the School of Rehabilitation Therapy, Queen's University, Ontario, Canada. Because my topic on the hypertonic pelvic floor disorder, the paradoxical puborectalis syndrome, I will be briefly discuss the anatomy of the pelvic floor muscles. The pelvic floor muscle is not a total or not a one layer. It is the pelvic floor muscles are 3 layers. The innermost layer or the deepest layer, it consists of levator ini muscles which is formed from the pubococcygeus muscle and puborectalis and iliococcygeus. This is the puborectalis muscle, the widest, and then this is the pubococcygeus, and this the puborectalis, which form a U shape and surround and originated from the back of the pubic bone to surround the rectum. And this is the iliococcygeus, and this is the ischio-coccygeus or the coccygeus. And this is the piriformis muscle, and this is the obturator internis muscle. So this is the deepest layer. The innermost layer or layer 2 will consist of external urethral sphincter that is here, and sphincter urethral vaginalis muscle, compressor urethrae here, and the deep transverse perineal muscles. While the layer 3 or the outermost layer will be consists of the pulpocavernosus muscle and the pulpocavernosus and ischiocavernosus and superficial transverse perineal muscle and external anal sphincter and the lower parts of the gluteus maximus muscle. So all of these muscle are supported are supplied by the motor branch of the pudendal nerve S234. What about the function of the female pelvic floor muscles? When to support the pelvic organs, such as the pubovaginalis muscle support the vagina, which in turn support the bladder and the uterus, and to provide volitional sphincteric control on the urethra, beside the internal urethral sphincter. And external urethral sphincter. The second function is puborectalis plays an accessory role to the function of external anal sphincter. So it helps in the continence of the stool. Number 3, the pelvic floor muscles counteract the downward thrust of increased intra-abdominal pressure. It is one of the local core that is responsible for supporting the spine and to prevent injury to the back. And the ischio-coccygeus help to stabilize the sacroiliac and sacrococcygeal joints. Number 4, it facilitates the anterior internal rotation of the presenting part of the fetus when it passes on the pelvic floor during the second stage of labor through the gutter-like action of the pelvic floor. Now we will take a look on the pelvic floor dysfunctions. Pelvic floor dysfunction is an umbrella term for a variety of disorders that occurs when the pelvic floor muscles and the ligaments are impaired. Pelvic floor dysfunction can adversely affect the quality of life of a woman, and they can occur during different stages of female life, such as during pregnancy, early postpartum, and during menopause. Pelvic floor dysfunction affect about 50% of women who have given birth, and epidemiologic studies indicate that approximately 1 in 3 to 4 women are affected by pelvic floor disorders, with the highest rates in the menopausal women. So now we will talk about hypertonic and hypotonic. Hypotonic pelvic floor dysfunction, for example, urinary incontinence, fecal incontinence, and pelvic organ prolapse. However, this is hypotonic, and hypertonic pelvic floor disorders may be in the form of dyspareunia, paradoxical puborectalis syndrome, the topic we will focus on it now, and vaginismus, primary vaginismus or secondary vaginismus, vulvodynia, and peduntal neuralgia. We will focus on paradoxical puborectalis syndrome. Definition: it is a spastic pelvic floor syndrome, and spastic, so it is not hypotonic, it is a hypertonic. And it is recently described as a subtype of the synergic defecation, in which the puborectalis muscle either paradoxically contracts or fails to relax during defecation, leading to lack of straightening of the anorectal angle and result in outlet obstruction. The anorectal angle is the angle formed between the posterior wall of the distal rectum here and the central axis of anal canal. And this angle normally measure about 108 degree to 127 degree at rest, with 15 to 20 degrees increase during defecation and 15 to 20 degrees during squeezing. This synergic defecation is common and affects about up to 50% of patients with chronic constipation. So it is a form of functional chronic constipation. It can occur in both children, adults. However, women more likely to complain from this issue than men. What about the causes? Causes may be summarized in there is a lack of coordination or inability to coordinate the abdominal muscles and pelvic floor muscle to facilitate defecation. The failure of the recto-anal coordination consists of inadequate propulsive force, paradoxical anal contraction, or inadequate anal relaxation. Thus, incoordination or dyssynergy of the muscles that are involved in defecation is the primary responsible for this condition. So there is a lack of coordination between the abdominal muscles because when a normal adult will defecate, the abdominal muscle contract and the pelvic floor muscle should be relaxed. So in this condition, the abdominal muscles contract, however, the pelvic floor contracts or fail to relax. So this is lack of coordination will result in chronic constipation of the patient. In addition to 50 to 60% of patients can also demonstrate impaired rectal sensation, as in cases of peduntal neuropathy. Some cases of extrapyramidal disturbance, as we know the extrapyramidal system that coordinate and facilitate smooth movement. So extrapyramidal disturbances like in Parkinsonian disease may affect this condition. Some spinal cord lesions, anxiety and spastic colon, anorectal malformation. All of these are causes and risk factor to paradoxical puborectalis syndrome. So we will take the patient history as a first step while we examine and evaluate the case. The patient may complain from these symptoms, and some signs may be examined, like lower abdominal rectal pain, tenesmus, that mean feeling of incomplete evacuation of the rectum, sense of pelvic heaviness. So this pelvic heaviness, because the stool is impacted on the rectum, this will not only make a chronic constipation, but actually this put a downward force on the pelvic floor that will lead to weakness, not only hypertonic, There is a misleading or misunderstanding between hypertonia and weakness. The muscle may be hypertonic and weak. So there is a sense of pelvic heaviness, and it may be associated with rectocele, like in this MRI image. There is a need to strain with bowel movement, difficulty initiating and completing bowel movement, chronic constipation, depression, or anxiety. So this will be the symptom. So now, how can we examine the pelvic floor muscles in this case? The first method to examine and evaluate the pelvic floor muscle status or condition, the first is the modified Oxford grading system. This is done through the physical therapist for women health may have wear a glove and introduce the index through the vagina, and will ask the patient to perform the maximal voluntary contraction. And this grading system will be indicator for the status of the muscle. So grade 0, no active muscle contraction. Grade 1, very slight flicker contraction. Grade 2, weak squeeze with no lift. So the patient is asked not only to squeeze or to perform maximal voluntary contraction, but actually to lift the pelvic floor muscle, as its function is to perform superior movement. So grade 3, fair squeeze with a lift. So from grade 3, there is a lift. Grade 4, good squeeze with a lift. Grade 5, strong squeeze with a lift. The second is the pelvic perinometry. Either Kegel or Bradford perinometry will be used before and after treatment to confirm objective strength of the pelvic floor muscles. It measures the intravaginal pressure or maybe the intrarectal pressure in this case, which reflect the force can be exerted by pelvic floor muscles. It provides sensory and visible feedback to the patient. These perinometers not only used for assessment, it can be used also for rehabilitating process, because it provides the patient with sensory and visible feedback. The 3, dynamometry. It is intravaginal dynamometers, can measure force directly and may yield more valid measurement than perinometry. It is inserted into the vagina and to assess the pelvic floor muscle function through measuring the pelvic floor resting and contractile force using the strain gauge mounted on a speculum, like in this. And the force will be displayed on this screen. Number 4, electromyography. The electromyography is the most accurate and objective method to record electrical activity during either rest and contraction of the pelvic floor muscles. It may be used through surface electrodes or through the needle electrode. However, needle electrode may need a certificate for physiotherapist in some countries. So this is the surface electrodes and this is the needle electrode. The needle electrode is more accurate than the surface electrode and actually more suitable for deep muscles like levator ani muscles. However, the surface electrode may be more suitable for the superficial muscles like external anal sphincter and superficial transverse perineal muscles. The 5th device can be used in the examination and evaluation is EMG biofeedback. It is a mind-body technique that involves visual and auditory feedback to evaluate and treat. Also, it is for evaluation and the treatment of different hypertonic or hypotonic pelvic floor condition. And it will be as a therapy. When we talk about therapy, it will be the good standard treatment for pelvic floor dysfunction like hypertonic, like paradoxical puborectalis syndrome. EMG biofeedback is a painless process that uses special vaginal or rectal probe to capture electric activity of the pelvic floor muscles, which is displayed on this screen. So this is the vaginal electrode and this is the rectal electrode. Okay, and the electric activity will be displayed on this screen. This is a relatively recent device, and I used it in my PhD. This is the Myotome Pro device. The Myotome Pro device is a handheld, non-invasive device that designed to measure muscle mechanical properties and viscoelastic properties. Has to show good clinical applicability and sufficient validity and reliability in different contractile and non-contractile tissue and disorders. While we use this device, we will gather information about tone of the muscle. So it is very effective and objective method to assess the tone of the muscle, because we are speaking on hypertonic pelvic floor. So if will characterize tone, and the biomechanical properties is that will characterize stiffness, discernment, and characterizing elasticity, while the viscoelastic properties are characterize mechanical relaxation time, and C is characterizing creeping. This is viscoelastic properties of the myofascia, pelvic floor myofascia, and this is the biomechanical, and this is the two. This is the method we can gather this information, and this is a study that support the use of myotone in detecting the biomechanical and viscoelastic properties of the pelvic floor muscles. Number 7, the elastometers. Elastometer were designed to assess the pelvic floor passive force. Okay? So the elastometer system consists of handpiece. This is handpiece comprising 2 aluminum branches with detachable acetyl plastic speculum tips, and real-time controller and laptop computer. It applies controlled stretch at a constant speed to the pelvic floor muscle in the transverse direction in order to assess pelvic floor passive properties without any negative or problems to the pelvic floor muscle, because it is controllable. Number 8, magnetic resonance with difficography. Here we need to just only know the H line and the M line. The M line is drawn perpendicularly from the posterior end of the H line, the PCL, the pubococcygeal line, from the posterior end of H line to the pubococcygeal line. This represents the descent of hiatus. Okay. However, the H line is drawn from the inferior margin of the pubic symphysis to the posterior aspect of the anorectal junction, and it represents the diameter of levator hiatus diameter. So this is the descent, and this is the diameter. And through through measuring the M line or H line, we can make a grading system for either the enlargement or the descent of the hiatus. And this is the normal characteristics and abnormal finding. Treatment of paradoxical puborectalis syndrome, there is it may be either conservative or surgical. Conservative, number 1, EMG biofeedback. In patient with dyssynergic defecation, the goal of neuromuscular training is twofold. Number 1, to correct the synergy of or in coordination of the abdominal, rectal, puborectalis, anal sphincter muscles in order to achieve normal complete evacuation, and to enhance the rectal sensory perception, especially in a patient with pudendal neuropathy. It is very important for physical therapists who deal with this condition to know that when we deal with hypertonic, because EMG biofeedback can be used in hyper or hypotonic. For hypertonic, we should begin with electrodes closely spaced, nearer, and sensitivity low to minimize crosstalk. Instruct the patient to relax using deep breathing techniques, visual imagery to help to lower the audio-visual signal. As the patient motor control progress, we can increase sensitivity. So we will begin with low sensitivity, progress to high sensitivity. And this study was completed by Simon. There is a biofeedback for 4 weeks, 2 sessions per week. So the total will be 8 sessions and 45-minute session duration. This produced significant improvement in the weekly defecation frequency and the decrease in the mean electromyographic activity of external anal sphincter. The clinical gains were maintained during the follow-up carried out 6 months later. So it provides long-term results. Second is spinal magnetic stimulation. Magnetic stimulation will be different from from the low frequency magnetic therapy. Magnetic fields increase the motion of ions, electrolytes in the tissue and the fluids of the body, so regaining the resting membrane potential of the cell. So if there is a decrease or increase or decrease in the cell membrane volts, that's the magnetic field will regain the balance again for the cell. Spinal magnetic stimulation through the magnetic coil placed at thoracic vertebrae 9 to lumbar vertebrae 3 for 10 minutes was very effective for and decreased. This is the Tesla, the 50% of maximum output, 2.2 Tesla. This value will be lacked in our physical therapy devices. So it is very effective when it is because the study support that 2.2 Tesla. 20 hertz, 1 session daily for 12 sessions may be benefit elderly patient with severe constipation associated with pelvic floor dysfunction. Number C, stretching of the pelvic floor muscle. Prolonged stretch inhibits muscle by stimulating the Golgi tendon organ reflex. Pelvic floor muscles can be stretched by cross-sitting position, squatting position, and knee to chest position. Defecation postural modification device like this also provide positively bowel movement duration and positively influenced straining pattern, complete evacuation of the bowel, and it offers non-pharmacologic option for this individual who suffer from inadequate bowel emptying and increased straining, because this is the difference between sitting and squatting. When sitting, the anorectal angle will be obtuse. However, in the less obtuse, and when squatting, the anorectal angle will be nearly to be straight, and this will ease the paths of the stool to the through the anal canal. In physiotherapy practice for a paradoxical puborectalis syndrome, biofeedback is the treatment of a choice for constipated patient with paradoxical puborectalis syndrome. Treating the cause of paradoxical puborectalis syndrome is very important in its prognosis, as in some cases like neurological cases. Pulsed magnetic therapy device usually utilize magnetic influx energy less than 0.4 Tesla, but pulsed magnetic stimulation, so this is the difference between stimulation and the therapy. The stimulation device, such as had been used in the previous study for puborectalis paradoxical syndrome, usually utilize magnetic influx energy near to 1 to 2.2 Tesla or more. Because we are speaking about the evidence, also because this problem may be recently investigated in physiotherapy, so low evidence may support the use of relaxation training. This low evidence come from expert opinion and maybe some case reports. Midland posterior anterior sacral glide grade 1 or grade 2 may assist in reduction of pelvic pain associated with pelvic heaviness. Pulsed shortwave on the perineum and sacral spine may provide deep thermal effect because it may penetrate to from 3 to 5 centimeters penetration that help to relax the spastic muscles. Low intensity shockwave and low level laser therapy may be beneficial in reduction of puborectalis paradoxical spasm and its painful trigger points, because these two modalities will increase the blood supply to the spastic pelvic floor and will decrease the sensitivity and hypersensitivity of the trigger points. Also, paradoxical puborectalis syndrome may result from some cases of endometriosis, because in the pelvic endometriosis, the endometrial tissue, when it comes outside the ovary, it may be infiltrating the pelvic floor muscles, and it will this tissue these tissues will bleed and will make adhesions that will provide will lead to hypertonic trigger points, and this will make the muscle at all in a spasm. So increasing blood supply and will assist in this condition. Number D, botulinum toxins. Botulinum toxins is the product of Clostridium botulinum anaerobic bacterium divided into 7 subtypes. Okay, botulinum toxin type 1 prevents the secretion of acetylcholine that cause blockage at the neuromuscular junction and cause temporary muscle paralysis. Botulinum toxin type A combined with pelvic floor biofeedback training seem to be successful for intractable paradoxical puborectalis syndrome. And in a systemic review included 7 studies, author concluded that initial satisfactory improvement of the symptoms after botulinum A injection remarkably deteriorated after 3 months. So it is advisable to combine botulinum toxin with biofeedback and manual pelvic floor physical therapy. The surgical procedure will be in the form of ileostomy or colostomy to evacuate the bladder, or in a partial division of the puborectalis muscle. However, this operation may result in fecal incontinence. Surgery may be offered after the failure of biofeedback and Botox injection, but it has a little or no role in these conditions. Thank you.